All right, hey everybody, let's rock and roll. Let's talk about the T waves and the ST segments. We've learned a lot about that this last week, and then practiced it in class on Monday. And we learned that the ST elevation means STEMI, and the ST depression means ischemia. But this is actually so much more to do with the ST and the T waves. I know this unit's huge and can be a little confusing, but hopefully you've gotten a good understanding of the basics, and we're just going to add to that with this lesson. Okay, so make sure you printed out your note sheet. I have my note sheet with me, and there will be a break in the middle of this, so I'll break and start a second video after that, just to keep them short and sweet, and so you have time to digest. Okay, so let's just go. Let's do this. All right, today we're going to talk about the causes of ST elevation, and then understand the different types of T waves, because we learned there's lots of different ones. There's peak T's, inverted T's, all that fun stuff, right? There are age differences on EKGs. I can actually tell the age of a person based on the EKG, believe it or not, you can. And then interpretation and some practice at the end. Okay, so these are our four major things we're going to talk about today. All right, so ST elevation we know as a STEMI, right? ST elevation is that ST segment elevated above the isoelectric line, right? So it can mean it's normal. Like we think of ST elevation as a STEMI, that's a heart attack. Uh-oh, something's wrong, right? But there's all of these other things that can come into play. I know it looks like a lot, right? We're going to figure out how to differentiate between the two, or between all of these, between an actual STEMI heart attack and one of these other things that's listed on here. Okay, so it actually can be normal in some situations. We'll get to that too. Something called acute pericarditis. So, as you know, the pericardium is that outer layer of the heart. It's kind of like a sac that surrounds it and protects it. Itis is inflammation, so that's an inflammation of the pericardium. So it's kind of like an infection. Something called early repole. So we know that the T wave is represents the ventricles repolarizing, right? And we have an early repole, so that causes a little bit of ST elevation there. Something called LVH, we've talked about quite a few times. A pulmonary embolism can look a little different, can look a little like a STEMI. Something called Brugada, hyperthermia, hypothermia, trauma, all these things can look like a STEMI. What? I know. So how the heck do we tell the difference at this point, right? It's just too confusing. Don't worry, we'll get there. We got this. It's good. It's all going to be fine. All right, so this is a normal ST elevation of 1 millimeter or more, can be seen in young active males age 17 to 25. Now, this right here is a normal inflection on someone who's young. And I think I mentioned this to you before. They did a study of over 6,000 young males that were in the Air Force or some other military category. And of those, not 6,000, that 6,000 is quite a lot. 91% of those 6,000 had marked ST elevation. Okay, and this is a normal, young, active, athletic male. They obviously do lots of running. They do calisthenics. They do all their, training at the outside on the obstacle courses and everything else. So they are very fit people. And they saw this phenomenon that was happening, this ST elevation, primarily in V1 through 4. Okay, notice they also have this really tall QRS. That's at LVH, right? So if you take this somewhat elevation, it looks different here, and pair it with the LVH, we have a very strong left ventricle and a little bit of elevation, and they fit into this young active male type. This is a normal EKG for them. Okay, we might see some of these in class. I know some of you are pretty fit. Some of the gentlemen in class are pretty fit. We might see some of this in class. So if I see some in class, I will point it out for sure. But this is what it kind of looks like. It's always in V1 through 4, and a phenomenon just happens with young active males. Okay, so acute pericarditis, like I said before, this is the pericarditis, the inflammation or infection in the pericardium that surrounds the heart. It is like a thin layer of skin, sac, if you will, that the heart sits into. So it's just an inflammation or an infection in that pericardium. So it swells, gets irritated, and it actually feels and mimics a heart attack. Okay, so it's going to feel like they have chest pain or pressure. They have some shortness of breath. They might have some palpitations, very weak, fatigue. This is usually palpable or like reproducible, they call it at the hospital. Like if you push on their chest in that area, it actually hurts because we're pushing against the pericardium. If you push in that area, you can typically, it makes it hurt more. So that's an indication for me that it might be pericarditis, that I can actually touch and feel their chest and it hurts just by touching. Okay, so that's not normally a heart attack. If you can touch the chest and it hurts, it's not normally a heart attack. It might be the muscles across the front of our chest that maybe our pectoral muscles, or it could be inside where the pericardium is inflamed. Okay, it does look like ST elevation. And again, we're here on the anterior region because you're going to feel it in the front. It's going to be typically in this V2, V3, 4 area here. So V1 through 4 in the anterior. You'll see some sort of ST elevation. It's not usually as high as we would think it would be for an MI, but it is going to be slightly elevated. Okay, so this would be a acute pericarditis. They all look very similar. You have to kind of go with your gut, the age, the symptoms, that family history, all kinds of things that are happening. All right. Okay, so here's what early repol looks like. So early repolarization is a form of ST elevation, but it has this extra little notch. It's called the J wave or the Osborn wave. So remember where the J point is, right? The J point, right here's our J point. When our ST elevation, we notice that it comes up to the top. It's well above the isoelectric line. That's our J point where the ST segment begins. Notice over here, we have this little notch, this little extra bump where the J point is. This is called the J wave or the Osborn wave. Okay, so when we have early repol, and again, I explained early repol before, it's kind of like this, again, we see this in young males or adolescents or those people that are physically fit. Males typically that are physically fit will have the slight ST elevation like we saw in the beginning, or they'll have this early repol. So the Osborn wave, J wave here. It can also kind of present itself as a little bit of a slur and or the notch. So this can be elevated, this notch can be elevated or right at the isoelectric line, but it's going to be a definite little Osborn wave, J wave. Okay. Again, early repol, remember the T wave is the repolarization of the ventricles, and this is just coming early. It's because the heart is accustomed to having to work hard and put out, so it's learned to do it early, so it's ready faster, ready to go to the next one. I see this a lot in like those marathon runners, sprinters. You see that because their heart is ready to keep pumping. It knows it needs a faster cardiac output or stronger cardiac output, so it prepares for it by early repolarization. It repolarizes early. That should make sense, hopefully. All right, if you didn't get it, pause it, go back and watch it again. We're also going to go over it in class. Just some more options or ideas of what early repolarization looks like. So here's our ST elevation right here. This is our classic ST elevation for like a STEMI. And this is the difference between the two. So you can see over here, the J point that we would see right here is normally would stay flat. It's going to have a little bump in it. So that's our J wave or Osborn wave. That is classic early repolarization. We also have a slurred one that comes down this side, kind of slurred down. This is also an indication of early repolarization. Just looks a little different. Or early repol can be nice and flat without the elevation, but still has that J wave or Osborn wave, that little notch, that little extra bump right there. Okay, so you see any combination of these three, it usually in that V1 through 4, then it's considered early repolarization. It looks like ST elevation at first, and you're like, oh no, STEMI. And you're like, wait, this guy's 24, and he's just having shortness of breath when he works out. Like, I don't think this is a heart attack. It would not be a heart attack. Got to take all those other things into consideration when we're interpreting and diagnosing. Well, here's our classic repol. There's our J wave, slurred QRS, and then the J wave or J point elevation. Yeah, okay. All right, so left ventricular hypertrophy. So this is the left ventricle is enlarged. So it's an enlargement or thickening of the wall. You can see the difference over here. It's a little bit different. This is much larger and stronger, right? In some cases, it's good. So in some cases, it's bad. We have all these different options here. So when it's bad, we have chronic hypertension. So this means someone has had untreated chronic hypertension. So high blood pressure, they've had it for a long time. This would be a heart of someone, say, in their 50s or 60s that's had high blood pressure and no medication for it. The heart is working overtime all the time. It's overworking. So it's become thickened. Usually, when the wall is thickened like this or extreme thickening of the wall, it doesn't work as well. Think of the dude, think of like the big bodybuilders. Okay. So it's one thing to be physically fit and you have muscular, definition. But think of the dudes that are like the bodybuilders. They're so big that their arms, like they can't even bring their arms down. They have to walk through the through the door sideways, right? Those type of people. Now their muscles are very hypertrophy, right? They're over hypertrophy. They're so enlarged that they have lost their elasticity. They don't have any flexibility. So instead of the heart squeezing and pumping like this, it's going because it's too big. All right. That's bad hypertrophy. Okay. Athletic hypertrophy is a little bit different. So it is a thickening of the wall, not quite as thick, but now think of our athleticism. So those people that are physically fit, that work out every day and have a muscular build, this is their muscular build inside their heart. So again, long distance runners, sprinters, like marathon runners, those people that do triathlons, their athletic hypertrophy in their left ventricle is normal and healthy. Okay. You occasionally will see this left ventricular hypertrophy because of a congenital disease like cardiomyopathy, where the heart is just enlarged. And again, that's bad, right? If it's enlarged in a bad way, then we've lost function because it's just too big. Okay. There's the cardiomyopathy, and then any type of valve disease. I'm going to double check here. Make sure on my notes you have what you need. Yes. And then it could be normal in children. So when you think of little kids and when they wake up in the morning, what do they do first thing? Head first, right? They basically run everywhere. They're basically little athletes. Number one, their heart is brand new, so it's super strong, right? It hasn't gone through years and years of use, and it hasn't been overused. And they basically run everywhere. So they have strong left ventricles, very strong. Their QRSs, in fact, tend to be really skinny and tall. That's how you can tell it's a kid's EKG. Can't wait to show you those because these are really cool. You'll see the difference. Once you start looking at them, you're gonna be like, hey, I can tell that that's a 3-year-old's EKG versus a 96-year-old EKG. Yeah. All right, so let's go through this. So this is LVH of with a large QRS and ST elevation. So this is an EKG of an athlete, typically a younger male athlete. Notice two things here. We see these really large QRSs, so large that they kind of run into each other on the paper here. Okay, so they overlap. These are very large. That means our left ventricle is enlarged, right? And we also see this ST elevation. Okay, so this is the healthy ST elevation that we saw in those athletes in the people that were in the Air Force. Okay, so this is actually an athlete's EKG. Looks a little wonky when you first look at it. You're like, wait a minute, this doesn't look right. But when you realize this person's just 25 years old and they're in the Army, then we're like, perfectly normal. But if this was a 75-year-old having chest pain, Houston, we have a problem. They have bad LVH and they have an ST elevation, so they probably are having a STEMI. So notice the age and symptoms and background is going to come into play when you're reading these EKGs. Here's an EKG of a 3-year-old. So when you take a look at a 3-year-old's EKG, again, notice right away, it's a little faster than ours, right? Faster. When a heart is smaller, it goes faster. So think of a baby that's born. A baby's heart is about the size of our fist. So think of a baby's fist, little tiny heart. The smaller the heart, the faster it beats. So babies beat, I mean, that's normal for them to beat at 150 beats per minute, right? This is a 3-year-old. They're probably active though, because this is a 300, 150. This is like about 150 beats per minute. They were probably active running around the house, okay? But notice the QRS, how tall it is and how skinny it is. It's very, very thin. You can barely see the QRS points, whether it be QRS. They're right next to each other. They're so small, so thin. Very tall, very skinny, okay? So another phenomenon that was going to tell me that this is a child's EKG is that most children have inverted T's in V1, 2, and 3. So I see the T wave is inverted here, it's inverted here, and it's slightly inverted here. It's kind of hard to see it. But I can know right away that this is a kid's EKG, primarily because that tall, skinny QRS and the inverted T waves, plus the heart rate's up a little bit. So that's a first indication to me that this is a young kid, okay? And if you weren't sure, rewind it and I'll go listen to it again. But tall QRS, that's real skinny with inverted T's, child's EKG. All right, so this is LVH EKG of a 60-year-old. Okay, so this is an older person with LVH. It looks like they also have ST depression as well. So they are, the LVH here is really tall QRSs. And notice it's in the leads that are down near the apex, right, where the left ventricle is located. So definitely 4, 5, and 6 because we're way down here, not near the left ventricle. 3 is kind of on top of the left ventricle, a little bit higher or towards the right a little bit, but these are all really large. And then 2, 3, and AVF are inferior, so these tend to be a little bit large as well. But that's going to tell us this is left ventricular hypertrophy of a 60-year-old. So this is not a young athlete, mostly because we see some ST depression and these tall QRSs. So you have these pictures on your paper. So I would on your paper just kind of circle what I talked about. I'll go back real quick. So for this one, I would circle this right here, ST elevation, and also the big tall QRSs for LVH in an athlete. Okay, so label that on your paper, LVH for athlete, circle the ST elevation and the very large QRSs. For the next one, this is, because you have a 3-year-old, so make sure you label that. That's the one at the bottom on your worksheet. And label that EKG of a 3-year-old. Circle the really tall, skinny QRS, write down that's tall, skinny QRS, and an inverted T. Inverted T's in V1 through 3, and the heart rate's elevated. So this all tells us this is a 3-year-old. And then for the 60-year-old, you also have that picture on here. I would circle the big QRS with ST depression. Okay, big QRS near the left ventricle, so V3 through 6. Left ventricle is down towards that apex, right? Circle the big QRS, LVH, and ST depression. We know this is an older person. All right, on to the next one. So pulmonary embolism. Pulmonary embolisms are, pulmonary means lungs. So this is inside our lungs. We have some sort of blockage inside our lungs. Okay, it's usually a blood clot blocking the blood vessels inside the lungs. So that can cause obviously lots of issues. Can't breathe, you throw a blood clot someplace else, it goes to your brain, all kinds of other things. So it's when one or more arteries in the lungs become blocked with a blood clot. Okay, they obviously are going to have symptoms of shortness of breath. They're blocked off some of the arteries. We're not able to get oxygen exchange like we're supposed to have. Okay, so they're going to be short of breath. It also causes chest pain because they have blockages in their lungs. So heart, as you know, sits right here and the lungs are right next door, basically right on, kind of on overlap on top of it. So if we have any chest pain in here, people mistake it for heart when it's actually lungs. So when I do this, I'm going to hook them up to the EKG machine. This is actually going to tell me if it's a pulmonary embolism or MI, right? We can tell by the EKG, believe it or not. Typically, someone with a pulmonary embolism is going to be a little tachycardic, not like severe tachycardic, but a little more tachycardic than normal, just mainly because they're having a hard time breathing. They're not getting enough oxygen, so their breathing is trying to compensate by getting more by going faster, basically. You're going to see some very deeply inverted T waves, and there might be slight ST elevation. Sometimes it's there, sometimes it isn't, but you'll see some deeply inverted T waves. But this is the kicker right here, this S1Q3T3. So what does that actually mean? So S1 is the S wave in lead 1. There's a picture on here too. So the S wave in lead 1, the Q wave in lead 3, and the inverted T wave in lead 3. So you're looking for those three things to come together. So you're looking in lead 1s and lead 1 and 3. That's Roman numeral 1 and 3. So those first two on the EKG, you're looking for that S wave to be kind of deep, and then the Q wave also to be deep, and inverted T in lead 3. So let's take a look. So this is what it looks like. So our S wave, so S1, S wave in lead 1 is going to be very deep, much deeper than normal. Okay. Then we go down to Q3, which is going to be our Q wave. It looks kind of like a pathological Q. Remember, pathological Q was a little bit deeper, a little bit wider. This looks very similar to that. And then in lead 3, you will also have an inverted T wave upside down. So if you look at this, just remember this formula, S1, Q3, T3. So S1 lead, the S wave in lead 1 is going to be deep and probably wide. Q wave in lead 3 is also going to be deep and wide. And then the T wave in lead 3 will be inverted. That is a for sure pulmonary embolism. And I see my docs in the emergency room when they see an pulmonary embolism EKG, they're like, we need an X-ray stat because we think he has an embolism. Yeah, stat. I have another picture here. All right, so this is an example of a pulmonary embolism, okay? Number one, it's a little bit tacky. His heart rate is about 120. Okay, heart rate's about 120. They have what's called an incomplete right bundle branch block. We haven't gotten to that yet. That's not super significant in a pulmonary embolism, so I'm not going to worry about that right now. But you're going to see those T wave inversions, specifically in this one down here, and then you'll see some might see some in V1 through 4 as well. But let's go through the S1, Q3, T3. So S1, lead 1, the S wave, QRS. Look how tall or how deep this S wave goes, way down here. Most of our S waves don't go that deep. Okay. Then in lead 3, Q is going to be also deep, sometimes wide, but it's much deeper than normal. And the T wave will be inverted in lead 3 as well. So you're going to look at the S wave in lead 1, the Q wave and the T wave in lead 3. You get those three things going for you, it's almost definitely a pulmonary embolism. Okay. All right, so Brugada, I actually have a friend with Brugada, diagnosed pretty young, as in 40. He's 40 when he was diagnosed Brugada. So it's one of those things you could run in the family, doesn't have to, but it can cause sudden death. So this friend was 40 when he was diagnosed, lost his dad at 42 of sudden cardiac arrest, and they don't know why because it was so long ago, but they're pretty sure that he had this same thing. So my friend has been diagnosed, and we know, or he knows that he has this and takes the precautions, takes the medications, all of that sort of thing. So it causes kind of like this disruption in its rhythm where it leads to like irregular heartbeats, like passing out, seizures, difficulty breathing, even stops the heartbeat. Okay. It doesn't come till later in life. It becomes apparent later. He was having some symptoms. He was actually having some chest discomfort, a little dizziness, shortness of breath. And he's very active. He's very athletic. He was playing tennis one day, which he does all the time. He's a very, very athletic, actually hardcore tennis player. And he was playing tennis this one day and was just not feeling right. And he went to the hospital, and here we go. He's diagnosed with Brugada. Yeah, crazy. So they did have to confirm it with genetic testing, but they did, yep, it's there for sure. And that's probably what his dad died of. So it looks like this kind of weird looking ST elevation, and it's called a saddlebag. So I'm going to show it to you. It usually comes in V1 through 3. There's a couple different stages or types of them, but they all look very similar. So let's take a look at this here. So this is what the saddlebag looks like. So it looks like elevation. So here's my V1. Looks a little elevated, looks like elevation. See how it looks like there's an isoelectric line and it looks like it's a little bit elevated or a lot elevated here. But it still looks different with this inverted T. It doesn't look like our regular ST elevation, does it? It looks very different. It's like this sliding slope down here. And then the saddlebag here. So you'll see this QRS come up, the ST segment will be higher, and then it slopes down and back into the T wave. Very odd looking. His looks just like this one. He's type 2. So it comes up and slopes down into the T wave. So saddlebag means it's the ST segment scoops down and comes back into the T wave. It starts up high, scoops, and goes into the T wave. So this is called brugada. Okay. So it can mimic a heart attack. You can have symptoms and stuff like that. When you hook it up, it looks like they have ST elevation. But if you look a little closer, you can see that there is this definite sagging of the ST segment. So the ST segment looks very different than just straight across. Okay. And if you want me to go through that some more in school, just show you some more examples, I can. Like I said, my friend was diagnosed, so I actually have some of his. Can't I have? Yeah. All right, so we'll get into hyperthermia and hypothermia. So you'll typically find artifact on a person with hypothermia because they're shivering, they're so cold. That's pretty common. But it's going to slow down the heart rate, obviously. If you have hypothermia, it's going to really slow down the heart rate. So hyperthermia, just because it's kind of putting the body into a shock situation. Anytime you shock the body, the heart rate kind of goes down. Okay, so we will see that J wave, Osborne wave that we talked about in early early repol. I was looking at precordial and moved, put them all together. So you will see here in our, this is very slow, by the way, 1, 2, 3, 4, 5 times 6. This is only 30 beats per minute. Okay, so this is a very slow heart rate. But you can see the J wave right here, that Osborne wave, J wave, that little notch, right? Little notch, notch, notch. That is the J wave or Osborne wave. So we see a really slow heart rate and we see that J wave, Osborne wave, it's usually has to do with hyper or hypothermia. And if they're freezing, right? Shivering, okay, you pulled them out of a river. I mean, it's pretty obvious. All right, the last one we're going to talk about is actual trauma to the chest. So if you have some sort of blow to the chest, so it causes some sort of contusion, it hits the heart valve just the right way, you get blow to the chest. Football players, baseball players get hit with a bat, a ball. You're in a bad car accident where the airbag hits you in the chest. Any blow to the chest can actually cause damage to the heart. Therefore, the ST elevation occurs. And also, your chest hurts, right? And then your troponin levels actually go up as well because now we've actually had damage done to the heart, so the troponin levels will go up. And you'll recognize the ST elevation. You'll see some tachycardia going on. You'll need to do some further testing here. A TEE, it's called a TEE, is a transesophageal echocardiogram. So echocardiogram is an ultrasound of the heart. Transesophageal across the esophagus. So they put a probe down your throat. Typically, they give you something to relax you, kind of put you in a conscious sedation. They'll put the tube down your throat, this little camera basically, and they're looking at the heart from a different angle. But you can see when a blow to the chest happens, if it hits those ribs just right, the ribs are there and then hit against the heart, and now we have some sort of damage. And occasionally it can cause an arrhythmia, can cause you go into VFib or cardiac arrest. That is what happened to, I'm going to say his name wrong, Damar Hamlin. Pretty sure. Football player, Damar Hamlin, where he got a blow to the chest and then just on the football field, and they were doing CPR and AED and all that stuff on him. He got hit just right. I would love to see his EKG and his troponin levels right after that. Love to. I know I'm such a nerd. Thankfully, all the right people there to help him and save him, and he is living an absolutely normal life now. So, I mean, it just happened he got hit just the right time in the right place, stopped all cardiac function of his heart and electrical conduction and everything, and he just dropped dead. Yeah, crazy, crazy stuff. All right, but it can mimic a heart attack, obviously, if you've had some sort of blow to the chest, and it does cause damage, so the troponins will be high. All right, this is where we're going to take a break. I'm going to stop the video. This is your video 1 for this lesson, and then you can be back, take your own break, and do the second video whenever you're ready. See you then.